Hello everyone, my name is Mandeep Dhanda. I'm the hospital transfusion practitioner and I'm just going to give you a quick induction on blood transfusion. So if we begin with our blood components, red cells, platelets, FFP, cryoprecipitate, which are UK donated and are strictly regulated by blood safety and quality regulations. And also our blood products, which you would also request from blood transfusion, human albumin factors like Octaplex and Anti-D, which are non-UK donated. If any patient gets transfused with a blood component, they are then no longer allowed to donate their own blood for the rest of their lives. And this is why quite commonly we get a blood shortage in the UK. And of course, all blood components and blood products must be fully traceable to the recipient for at least 30 odd years. So if we go on to Walsall Manor Hospital site, our main blood fridge is located behind the atrium. So as you enter the hospital, behind SPA. And this is regulated to be kept at 4 degrees Celsius, and we must maintain the product liability of all of our blood components. Because it's so far away from our inpatient areas, we have a 30-minute rule where once the unit has been collected, the transfusion must commence within 30 minutes or the unit must be returned back to blood bank as soon as possible within those 30 minutes. This is why we insist that all patient observations and cannulation are carried out before collecting that unit of blood. Again, the entire transfusion process of that unit should not exceed 4 hours. So we ask you to transfuse blood components at a rate no longer than 3 hours. And of course, that pathology issue fridge also contains 2 emergency O-negs to be used in a major hemorrhage situation. So here at Walsall Manor Hospital, we do use the National Blood Transfusion Committee's guidance for the use of blood components. So you will have to select one of these indication codes when requesting blood on your request forms. So for example, if your patient's having a major hemorrhage, it'll be R1. If your patient's severely symptomatic but stable, it's R2 with a HB of less than 70. But most patients will have a threshold of 80 grams per litre, which is R3. We also have got both acute and surgical iron deficiency anemia pathways, where if somebody presents, let's say, to A&E with a low HB, please take some baseline blood samples, which includes the yellow top hematinics test, which tests ferritin, B12 and folate levels. And if the ferritin does come back as low, please give them iron therapy and put iron deficiency anemia on their EDSs. So you could give ferrous fumarate, ferrous sulfate tablets. However, as we know, a lot of patients don't tolerate oral iron supplements. So we can actually give them Ferinject, a quick 15-minute iron infusion, which will replenish their iron stores. And of course, if they are severely symptomatic, it may be of use giving them a single unit transfusion as well. We do have a medical day case facility situated in the clean COVID area. So next to Trust headquarters, it's Route 106, where you can send your prescriptions and the patient can come back and book into a slot between 9 till 5 for either their transfusions or their iron infusions. We are running this campaign. Please don't give 2 units without review. If your patient is not actively bleeding, please only request 1 unit of blood and then reassess your patient once that 1 unit transfusion has finished. It may be that you have to take another full blood count. FFP we keep frozen in our blood bank and we only thaw it out on request. We don't have pre-thawed plasma here because we find it quite wasteful. So please give us advanced Warning if you're going to transfuse FFP. If you're transfusing FFP in a major hemorrhage situation, in a trauma situation, please request on a 1-to-1 ratio with red cells. But if your patient's having a major obstetric bleed or a GI bleed, please request on a 2-to-1 ratio with red cells. For paediatrics, we also have paediatric units and low volume units, and this should be prescribed at 15 mils per kilogram. Again, transfusion should be finished within 4 hours. And if your patient has got deranged clotting because they're on warfarin, we do have Octaplex in blood bank that you can request via the same way that you request all blood components. But of course, you have to have consultant authorization. So if you go through switchboard and get hold of a consultant hematologist. Seek advice from a consultant hematologist also if your patient is on a direct oral anticoagulant such as apixaban, endoxaban or rivoxaban for reversal of this as well. Again, use the National Blood Transfusion Committee's guidance for requesting FFP. So if your patient's having a major hemorrhage, select F1 when requesting. But the target FF-INR should also be below 1.5. Platelets. We do not hold any stock of platelets. We only get them here once they are requested from yourselves. So we can get them here in an emergency or a blue light or using one of our blood bikers within the hour when requested. Because these are kept at 22 degrees and they love bacteria, your patient is more likely to react to a bag of platelets than they are to the red cells and FFP. And this is why we like to transfuse these stat and well within the hour. Again, National Blood Transfusion Committee's indication codes for platelets is if your patient's got reversible bone marrow failure, the target platelet count should be 10. If your patient you suspect of having sepsis, target platelet count should be 20. And of course, a major hemorrhage, always keep the platelet count above 50. So we do have specific blood transfusion, prescription transfusion records that we keep on the wards. Where those are kept, there's also some patient information leaflets called Will I Need a Blood Transfusion? A really good leaflet which will let the patient know exactly what the risks are at this current time of having a transfusion. Of course, what it doesn't tell them, we do not test our units for COVID. We only test for HIV, hepatitis B, C, E, and syphilis. So if you wish to prescribe a blood component for your patient, simply fill out the patient details on the top left-hand side. Of course, you can use an addressograph label for this. Put down your name, reason why you've decided to transfuse the patient, any pre-transfusion results, any special indications, such as if your patient's had a solid organ transplant or a bone marrow transplant. It could be that they need irradiated blood. If they're a child below the age of 1 or an expectant mother, they should have CMV negative blood. If they are having a rapid transfusion or have got a low platelet count, which actually reacts up below 37 degrees, you could use a blood warmer. So please make sure these are selected because in some areas they don't have this equipment. Once a patient has consented, you can just tick this box here, and when you've given a patient information leaflet, a consent must be recorded. If we're unable to gain consent, please record it in the health records. Put down the date, product prescribed, and the rate, which should never exceed 3 hours, and your signature. Then this is just a step-by-step process of what the nursing staff have to do next, such as if, let's say, they start the transfusion or scan out the transfusion at 10 o'clock, they know to start it by 10:30 and to end it by 2 p.m. 2 people who do the bedside check should sign here. And of course, this box will prompt them when to do the observations on Vital Pack. And fated by is when we take the empty bag back to the nursing station and scan it as used confirmed. And this is a log that we keep on file for at least 30 odd years for traceability requirements. So if anything goes wrong with a transfusion or whether a patient reacts to a unit of blood, please report it on the Safeguard intranet site. If anything goes wrong with a transfusion, we are legally obliged as a trust to notify the shot agency within 24 hours, and they categorise these events and give us feedback year upon year. So as you can see, this is feedback we received this year. The items in blue bars are things that were not preventable, things like febrile, allergic, hypertensive reactions, cell salvage issues when potentially it wasn't used. So this is why we do a full set of observations before we start the transfusion. We do another set 15 minutes after commencing the transfusion, because this is when the patient is most likely to react. And then, all being well, another set at the end of the transfusion. If you suspect your patient of having a reaction, please stop the transfusion as soon as possible and notify the consultant haematologist via switchboard immediately. All the errors in red and orange are due to human error and were preventable, and this is the ones that we really need to minimise in this trust. As you can see, the top one is the most reported item, which is near misses, and they tend to be wrong blood in tube instance where we've taken wrong specimens from the wrong patient. So I'm just going to go back to basic, what is a group and save, because this does confuse a lot of people. So a pink top tube, a group and save, when you request this, is just when we group the blood inside and check for any antibodies, and we keep it on hold for 72 hours if your patient's had a recent transfusion, or 7 days for patients who haven't had any recent transfusions. So if your patient all of a sudden does require a transfusion, all you have to send is a second form. Okay, so and then we just use this sample and check and confirm the compatibility of each red cell unit. So we have gone to the 2 sample rule, where we will not give any patient an ABO compatible transfusion unless we have 2 samples taken from the patient completely independently of each other. One can be historic, so let's say a patient's come in and they've had a group and save taken 2 years ago, and we can check this via our patient information site at Fusion and laboratory. If they've had a sample underneath blood bank topic, then we only have to take 1 sample on this admission. This is to prevent a wrong blood in tube. So wrong blood in tube is when we take a sample from patient A, but label the pink bottle with patient B's details. So automatically we'll be testing patient A's blood group, patient A's HB perhaps, but assigning it to patient B. So if patient B ever gets prescribed blood, or whether they get issued blood, no matter how many checks you do after that point, we're not going to know if the patient's having an ABO compatible transfusion until it's too late. So both samples have to be accurately taken and labelled, and if there are any discrepancies, they will be reported as near miss never events. So again, our laboratory services have been taken over by Black Country Pathology. So they rely on yourselves to identify the right patient, take the right specimen from the right patient, and if they can read all the writing on the tube, or if it's matches all the patient information systems they have in the laboratory, then only then will they accept it and go ahead with testing your blood components. If they are not happy with it, they will reject it and ask you to rebleed. So how do we make sure we don't have a wrong blood in tube event? Well, we go onto our Fusion website, we select our patient, we go to order request, where we can request any blood samples, go to transfusion services, and it will come down with a drop-down menu of our transfusion requests. So at the top here, we have all our tests, such as group and screen. So if you select that, you're telling us to group your patient and do a full antibody screen. And then we will reserve it for either 72 hours or 7 days. If you need to request blood components or blood products for your patient, simply go to the lower half of this menu and select your product. So let's say, for example, for our patient, we're going to select red cells. So we will click on that. Then it will ask you to specify how many units you require. Please be aware we have got a blood shortage at the moment, and every time you request blood, we are reserving it for your patient for 24 hours, so taking it out of our issue fridge. So if your patient's not actively bleeding, please only request 1 unit. So put 1 in there. So let's say we want to select 1 unit. It will then ask you if your patient's having a specific procedure, because we do audit all our procedures and check blood loss per surgery. Any special requirements, such as your patient having irradiated CMV neg products. And of course, please fill in your patient's obstetric history. Really important, particularly if we find that your patient has got a positive antibody test. We need to trace back where they were potentially sensitized. So because we requested red cells, it automatically asks you to select your national blood transfusion indication codes. So let's say we want to select R2. Our patient is stable, but the HB is below 70. SHOT have recommended that every patient goes through a TACO assessment. This is because our biggest, most transfusion-related death in recent times has been transfusion-associated circulatory overload. So it will ask you if your patient is at risk of this. If you need more information, just simply click more info and it will ask you a series of questions to check if your patient is at risk. So it will ask you things like, is your patient suffering from cardiac failure? Is your patient on a regular diuretic, or is known to have pulmonary edema? If the answer is yes to any of these questions, then your patient is at risk of TACO, and then it will give you suggestions on what you need to do. So such as, does this patient really need this transfusion? So do the benefits outweigh the risks? Or can we get away with an alternative therapy such as iron? And of course, if you do want to still commence with the transfusion, consider the patient's body weight, their fluid balance, and only request a maximum of 1 unit. So then hopefully your request form should print out. So this will automatically formulate your patient's details, such as a first name, surname, NHS number. So when you do print it out, simply sign it and put your contact details there. Then this can be used as a sort of pre-identification check to check your IT systems, check the spelling of their name, and check that John Smith is quite happy with the way their name is spelt. And then you'll check that the patient also is wearing a wristband. So no wristband, no transfusion. So if you need to bleed your patient, ask your patient an open-ended question. Please confirm your first name, surname, date of birth, if possible. Of course, if they're unconscious, you've only got their wristband to go by. And once you do take the sample, particularly the group and safe pink tap samples, they must be completed at the patient bedside, handwritten and signed, and the writing must be illegible before sending over to blood bank. I'm just going to go through the major hemorrhage protocol. So we do not have trauma packs or hemorrhage packs as of yet at Walsall Manor Hospital. In fact, most hospitals are moving away from these because they're deemed quite wasteful, particularly in recent times when there may be a massive shortage of ONEG. So the leading clinician, medical coordinator, activates a protocol. They should assign one person as the communication lead and one person of the nursing staff, such as a staff nurse or a CSW, as the runner. Really important to send the runner as soon as possible to start collecting the blood components and fetching them back to your patient's bedside and clinical area. So the communication lead simply picks up the phone, calls blood bank. This is vital. I know sometimes we call 2222, but please go ahead, use the same phone and phone blood bank direct, because we really need to know your patient details. That allows the biomedical scientist downstairs to relay back directly to the communication lead whether your patient needs to have 2 samples taken or 1 before we will give an ABO compatible transfusion. So let's say John Smith is bleeding and you want to activate the major hemorrhage protocol. Ring blood bank, give John Smith's full name, date of birth and NHS number. Let's say John Smith has been here historically. So the biomedical scientist will say, oh, we only need 1 sample from this admission before we can give ABO compatible blood. You know to send the runner with those samples and the prescription record with the patient's full details down to blood bank, and that allows us to start issuing out within 10 minutes the patient's own blood group. So let's say John Smith is A-pos, you've sent the second sample to us. Within 10 minutes, we'll just issue out some A-pos blood labelled up with John Smith's details, and as the runner's running back to the clinical area and as you're transfusing it, we will do the compatibility studies retrospectively. So within 45 minutes, you will know whether it's fully compatible with your patient or not. Okay, more than likely, we do know the patient's blood group. If, let's say, the patient's attended A&E and we don't know this patient, we need 2 group and save samples, then we can relay that back to the communication lead. So the communication lead can assess the situation, know that it will probably take half an hour to take both samples. So they know to send the runner down for emergency O cells. So if we haven't received the second sample, we will automatically give the runner O negative units if it's a female of childbearing age bleeding. But if it's a male patient or a female above the age of 50 bleeding, we will give emergency O-pos units. That's because 7.5% of the population are O negative. But because we're using it in major hemorrhage situations, we're using it 10 to 11% of the time, which creates a massive deficit and a shortage in Britain. So we tend to revert to O-pos and keep the O-neg for females of childbearing age. So when your runner comes back to clinical area with these red cells, please send them straight back to blood bank and start collecting the other products such as platelets, FFP, cryoprecipitate if needed, which will take longer to thaw out, perhaps a 25-minute time frame from when you've activated. Also remember, routinely after each batch of products have been transfused, take a set of samples which should include full clotting screen and fibrinogen levels, so it gives you a guided approach on what to transfuse next in a major hemorrhage. Last but not least, Final check we should be doing at the patient's bedside is with the blood component tag and the patient's wristband, and if with the patient as well if they're conscious. So ask the patient their full details. So check all these details on the tag and the wristband. Check the expiry and check the blood groups. Hand it over to your registered colleague and they should do the same. Just to give you an update, we have gone live with the convalescent plasma arm of the recovery trial. So if a patient is suspected or has come in with a positive COVID test, please recruit them into the recovery trial, and then they will be randomised on to receive convalescent plasma. If you wish to donate plasma yourselves, you can go on to the NHS Blood and Transplant website, click on the convalescent plasma button, and it should give you details on where you would donate. But this is our Hospital Transfusion Committee Chair, Dr. Chris Newson. If you have any questions about convalescent plasma, please collar him in the corridor and ask him. He has already donated twice to the plasma trial, and he'll give you more details as a primary investigator. Last but not least, if you have any questions regarding blood transfusion, please contact myself, Mandeep Dhanda, at warsawhealthcare.nhs.uk, or alternatively you can bleep me on 9091, and if I'm in my office, which rarely happens, it's extension 6252. Or if you need any further information such as quick flow charts on the major hemorrhage protocol, just type in blood transfusion into the intranet and the policy should appear. I know you don't want to read the entire document, but there are some flow charts in the appendices, including octuplex dosage charts. Thank you for listening. Hope to see you around. Goodbye.